is continuously increasing. And it is not only a maker of mortality, it is also a maker of cardiovascular mortality. You may ask me as to how people with kidney disease die. They don't die of kidney failure as such, but much before that, they die a cardiac death. They have a myocardial infarction. They develop congestive cardiac failure or peripheral vascular disease. So they die a cardiac death much earlier than they are ushered in to the dialysis room. And you see that the causes of chronic kidney disease are multiple. Towering above everything is the diabetes, and coming close to it is hypertension. And the third place goes to a group of diseases which are mostly autoimmune in phenomenon, chronic glomerulonephritis. You also have a fair share of calculus disease or renal stone disease, which can progress, and also certain genetically predisposed diseases like autosomal dominant polycystic kidney disease and others. The common paradigm that we have been using in treating this chronic kidney disease is that we start using angiotensin receptor blockers or ACE inhibitors. So we want to curtail the renin-angiotensin system. So we use either of these drugs. And over the last 10 years, we have increased our armamentarium. Now we have the so-called sodium glucose co-transporter inhibitors, the SGLT2 inhibitors, which has come in and hit the market very powerfully. And it seems that everyone of people with chronic kidney disease and also with cardiac disease is put on this drug. There is also a third category of groups of drugs called the mineralocorticoid receptor antagonists. You also have the glucagon-like peptide 1 analogs, and the majority of the antihypertensive drugs like calcium channel blockers, beta blockers, and centrally acting drugs. All these also provide a very good effect on the progression of chronic kidney disease. But what is very unfavorable is that even with all this, when we throw all these drugs onto the patient, these patients continue to progress. Their kidney failure continues to go downhill, and they progressively reach a stage where they have to be taken up for dialysis or they have to be taken up for kidney transplantation. So if you go into the microscopic details of the glomerulus, you can see that you need to protect the glomerulus from the hemodynamic and immunological injury. The pharmacological approaches are depicted here by providing lowering of the proteins in your diet. You can produce some degree of reduction in the afferent arteriolar diameter so that the blood flow is to some extent reduced inside the glomerulus. So the glomerular hypertension can be to some extent lowering. Lowering of the glomerular hypertension is possible. The second aspect is, as I already told you, by giving SGLT2 inhibitors, you can, by reflex mechanisms, which I will not go into the details, there is some degree of afferent arteriolar vasoconstriction. This again is beneficial for the glomerulus. And the third aspect is RAS blockers, where efferent arterioles are dilated. So in effect, you are going to reduce the intraglomerular hypertension by all these methods that I have enumerated. A low sodium diet also contributes, and it reduces the intraglomerular pressure. But we need a paradigm shift in our management of chronic kidney disease. This has been my lifelong passion of using drugs to reduce phosphorus in the serum with which has got multi-pronged benefits, and reduction of the acidosis will prevent the bone disease and renal progression. So let us come to phosphorus. Phosphorus with an atomic number of 15 with a mass of 30. And phosphorus was ushered in to the earth by meteorites. It was not immediately present during the Big Bang, but after the nuclear fusion in the dying stars, which happened 8 billion years ago, phosphorus was born. And the meteorites showered it onto the earth, and life began in all its complexity on the earth. You have the RNA, the DNA, phospholipids, ATP. All of these are the backbone is phosphorus. The distribution of phosphorus, 1% of the total body phosphorus only is revealed in the serum or the plasma. And 15% of the plasma is present in the intracellular tissues and muscles. And 85% of the phosphorus is present on the bones and teeth. And increase in the serum phosphorus is both a marker and a maker of mortality. You can see that with every blip in the serum phosphorus levels to increase, the whole all-cause mortality increases. A meta-analysis data where more than 327,000 people with chronic kidney disease were analyzed. It showed that for each 1 milligram increase in serum phosphorus, there was an 18% increase in the all-cause mortality and a 10% increase in cardiovascular mortality. Even in general population, higher serum phosphorus levels increase mortality. So it is not only in people with chronic kidney disease or people with renal failure. Even in the general population, if you check the serum phosphorus levels, if you find it on an increase, then higher serum phosphorus is associated with increase in mortality. The reason is not far to seek. Sir William Osler, the real father of modern medicine, had remarked that you are as old as your blood vessels. You are as old as your arteries. So whenever the arteries become old with the calcification, with phosphorification, so calcium and phosphorus get deposited into the vascular tissue. You can see that how abdominal aorta gets calcified, and you can see how it is looking like the anaconda, snake of anaconda. And you can see how coronary arteries are calcified. So this is taken from a patient with chronic kidney disease. The reason why calcification occurs is because body struggles to reduce the phosphorus levels when GFR reduces. When the glomeruli shut down, then all hell breaks loose and serum phosphorus levels go up. Normally, the dietary phosphorus intake is anywhere between 1 gram to 1.5 grams. And I'm sure in American food, you will find a lot of phosphorus coming from additives, etc. The fecal phosphorus is around 900 milligrams. The phosphorus absorption, again, is close to a gram per day. And there is a dynamic situation which is existing where phosphorus can come from the bone and again can get deposited onto the bone. And it can go to the kidney and it can also get reabsorbed from the kidney. So you have a dynamic situation which is interplayed by multiple hormones. The two major hormones being the parathormone and the FGF23. This FGF23 is a new player which we have recognized recently, where it is known to come from the bone tissue, the osteocytes, and it is one of the important triggering points of increasing serum phosphorus. Once serum phosphorus levels go up, FGF23 immediately starts revving up, and it reduces the phosphorus absorption from the tubules. So when renal failure sets in, the renal tubules can no longer excrete phosphorus, and this increase in the phosphorus in the serum increases the calcification in the bony in the vascular tissue. And the serum phosphorus rises late, but you can see that the serum FGF23, the hormone, starts rising even when the GFR is close to 70 ml per minute. That is why we say that we need to start our therapy much before the patient reaches CKD 3. We need to reach them early in CKD 1 or 2 when the GFR is close to 80 to 100. And the guidelines tell us that we need to keep the serum phosphorus levels between 2.5 to 4.5. And you need to reduce the elevated phosphorus levels. So why are we failing to reduce the phosphorus levels? This is because of our indulgence in heavy animal food intake, and also in the additives, which are very common in the fast food that we take on a daily basis. And these additives have an increased propensity for phosphorus absorption. The phosphate binders that we are all familiar with include the calcium carbonate, the calcium acetate, and also the newer calcium phosphorus binders like the sevelamer, the iron-based phosphate binders, etc. They all have come with a major problem of pill burden. You need to take multiple pills to reduce the phosphorus levels, and this really reduces the compliance. The patients, after some time, he thinks that he's taking too much of tablets, and in the end, he stops the tablets altogether. So you can see here that anywhere between 6 to 8 tablets are required to produce phosphorus control in patients with chronic kidney disease. If it comes to aluminum calcium acetate, 4 to 6 tablets, calcium acetate and magnesium carbonate, sevelamer carbonate, 4 to 8 tablets, lanthanum carbonate, 3 to 4 tablets, sucropheric, 3 to 4 tablets. So multiple tablets, and you need to add these tablets to the already present list of antihypertensive drugs, anti-diabetic drugs, and you can see that these patients have a handful. Their hands are full of tablets, and they seek to reduce the tablet load by non-compliance. So the challenges of the current drug are the cost of the therapy, the pill burden, and the side effect profile, and also vascular calcification. So non-compliance rates are as high as 40% in patients with chronic kidney disease. A common lament is that despite the availability of several phosphorus binders, an ideal phosphate binder that combines a high efficacy, low pill burden with minimal side effects and low cost is still not available. So this is the big lament, and this is where we come in. And this is where the even dietary niacin intake has been shown to have a salubrious effect on progression of chronic kidney disease. So it is beneficial to even take dietary niacin on a daily basis. So it is available in a variety of animal and plant-based diets. And so you can take it, and you can see that the an inflection point whenever the dietary niacin levels uh, go down below 22 milligrams per day, then there is an elevation of the progression of chronic kidney disease. So this is the inflection point. So anywhere between 20 to 30 milligrams per day of niacin, if you take naturally also, you are protected. So it can be added as a food supplement. The association between niacin and CKD is consistent. So with every reduction in the levels of niacin intake, there is an increase in the progression of chronic kidney disease. And you're able to see that if you increase the niacin intake, even in your diet, the chronic kidney disease risk is reduced. So the US RDA says that it is 16 milligrams per day. Ideally, if you take close to 25 to 30 milligrams, it is ideal for physiological purposes. The niacin comes from the tryptophan, which is 1 gram per day, which is niacin equivalent, or nicotinamide riboside. The pharmacological method that we have been using all these years, or more than 50 to 60 years, is large doses, more than 1.5 grams to 4.5 grams per day. And these large doses can produce some adverse effects like hepatotoxicity, hyperglycemia, hyperuricemia, and gout. So this gave a bad press for the niacin, and so the public is discouraged to use this very beneficial vitamin on a daily basis. So unfortunately, this is a fact, but by reduction of the dose of this niacin, all the beneficial effects, as we shall see, can be very usefully taken up. The smaller doses are effective without major side effects. The reason how phosphorus levels come down with niacin is that in the duodenum, you have a transporter called the sodium phosphorus transporter, co-transporter, which is predominantly expressed in the duodenum and the jejunum. So when niacin is given in small doses, as low as even 100 milligrams per day, very, very small doses, you are able to reduce block this sodium phosphorus co-transporter so that this phosphorus cannot get absorbed and it will be excreted in the stools. And so this made me to write a commentary that niacin for the phosphate control, a case of David versus Goliath. The reason why I have captioned it is this, that the pharma companies are not really interested in manufacturing this very cheap vitamin for large-scale use. And that is why it has not seen the light of the day in most of the prescriptions. So if you're able to use it in small quantities, in small doses for people with early stages of chronic kidney disease, you will gain a lot of benefits. And when I published my results way back 20 years ago, this was corroborated by multiple studies across the world, from the South America, from the Germany, from Iran, and from USA, and in multiple countries. So this was the first publication, which was published in the International Journal of Urology and Nephrology, extended release nicotinic acid. So a single dose of 375 milligrams was given, and you can see that the phosphorus levels came down. So if you're able to reduce the phosphorus levels, we'll see how renal progression can be positively impacted. And this is again another view of from the developing countries, where multiple investigators have shown that this drug can positively impact with a very low dose. And recently we have a Dutch study which told us that niacinamide supplementation on phosphate concentration in the dialysis patients, and thrombocytopenia was not seen. You can see that this Diania Dutch study, there was a reduction in the serum phosphorus levels. So a single dose of, again, this drug in the slow niacin trial, which came from Canada, told us that a significant reduction in the serum phosphorus levels happened. The absolute difference between the groups was minus 3.35 millimoles. And this was again came from Iran, where they used, again, very small doses, 25, 50, 100 milligrams of niacin, and they found that the phosphorus levels came down dramatically within 1 month. So these are all very beneficial effects. HDL levels went up. So when we reduce the phosphorus levels, how chronic kidney disease can be positively impacted? You can see that chronic kidney disease involves progressive tubular dysfunction and metabolic derangements. And recent interest is there on the niacin's effect on not only on the phosphate handling, but also on the NAD metabolism, which is really a powerhouse of how the ATP is generated in the mitochondria of every cell. Mitochondrial function in the renal tubular cells. So loss of peritubular capillary perfusion and tubulointerstitial inflammation and fibrosis happens very early in chronic kidney disease. And so mitochondrial dysfunction and ATP depletion are very, very early phenomena seen in chronic kidney disease. So when you have this, then the progression of chronic kidney disease develops. So by using niacin, which will provide a base for NAD repletion, you're able to reduce the mitochondrial dysfunction and also free oxygen generation. Oxygen radical generation is also reduced. And you can see that niacin also inhibits the hepatic diacyl glycerol acyl transferase 2, right? And so it reduces the triglycerides. Triglycerides also there are receptors on the mesangial cells for triglycerides, and progression of chronic kidney disease also can happen when triglycerides levels go up. And so we require to energize the renal tubules, and niacin is a very good drug to energize the renal tubular mitochondria. And there are also, it can activate the GPR 109A, which is an anti-inflammatory effect. So it reduces the phosphorus absorption from the proximal tubule, and it improves the FGF23 levels. So impact on the NAD and mitochondria, you can see that the niacin increases the NAD plus levels via the Price handler pathway and enhances the mitochondrial biogenesis, reduces the oxidative stress in the tubular cells. So during the COVID pandemic, in the Mass General Hospital, a study was undertaken where they used nicotinic acid, niacin, and niacinamide for people with COVID-associated acute kidney injury. They found remarkably that this drug, niacin, could reduce the progression to requirement for dialysis in patients with acute kidney failure. And you have to understand that acute kidney failure and chronic kidney disease are two sides of the same coin of renal disease. So if you're able to abrogate the acute kidney injury, you're able to abrogate the progression of chronic kidney disease. So progression of chronic kidney disease from acute renal failure also is a major threat in most of the countries, and you can mitigate by using niacin. So anti-inflammatory effects and anti-fibrotic effects are also there. You are able to reduce the nuclear factor kappa B signaling, thereby reducing the fibrosis. You're able to reduce the inflammatory milieu inside the renal tubules and the interstitium. You are able to reduce the interleukin 6 and the TNF alpha levels. And so it can reduce the fibrosis and slow progression via tubular protection. So I told you multiple benefits of using this drug early enough to retard the progression of chronic kidney disease. The safety factors also come in only when you use in large doses. Flushing is a problem in the first few doses, but you can beneficially alter it. Hepatotoxicity is seen only in very high doses. We don't use high doses. Glucose intolerance, again, is a problem in high doses. We don't use such high doses. So in patients with chronic kidney disease, you require dose titration. Start on a low dose and go slow. And another factor which we have recently seen is the niacin intake also impacts the renal stone recurrence. So renal stones also can be positively reduced by taking niacin. And you can see here again, when the niacin intake is below 35 milligrams per day, again, there is an increase in the stone risk. So an L-shaped relationship suggesting that within the range of 0 to 35 milligrams per day, higher niacin consumption was significantly associated with a lower risk of renal stone disease. So it's a very attractive candidate. It modulates the renal tubular metabolism, reduces the phosphate reabsorption, and improves the bioenergetics and reduces the inflammation. And you require long-term RCTs and also some biomarker validation. You require tailored therapy for chronic kidney disease in stages. The second aspect is acidosis correction. Acidosis is again a major issue in patients with chronic kidney disease because there is a lot of muscle catabolism which is happening, and the renal ammonia generation comes down in patients with chronic kidney disease. And ammonia, as we know, is an important molecule which excretes the hydrogen ion via the urine. So when ammonia generation is reduced, ammonia genesis is reduced in chronic kidney disease, then the hydrogen ions cannot get excreted into the renal tubules, and so acidosis sets in. And acidosis has got very deleterious effects on the various body systems. The bone, for one, there will be bone resorption, and you can see that these people are more prone for the bone resorptive issues like fractures and also renal osteodystrophy. The acidosis not only impacts the bone, but it can also have a deleterious effect on the progression of chronic kidney disease by producing increased complement activation and RAS activation, and produces interstitial fibrosis. So plant-based diets, as you know, contains a lot of alkali, and even if you give alkaline source with the help of soda bicarbonate orally, you're able to reduce the progression. So decreased bone resorption, the GFR can be preserved. The insulin sensitivity also improves, and the muscle toxicity is reduced. So what is the sweet spot of serum phosphorus levels, serum bicarbonate levels? The ideal serum bicarbonate level is somewhere between 22 to 24 to 25 milliequivalents per day, per liter. So when you are able to keep the serum bicarbonate levels in this sweet spot, you're able to reduce the multiple deleterious effects. So the so-called baking soda or the sodium bicarbonate retards the progression, and it inhibits the complement-mediated inflammation in the interstitium and improves the muscle metabolism. And a tablet of 500 milligrams of sodium bicarbonate contains 6 milliequivalents of bicarb. And hypertension is not a side effect. You have to understand that the chloride ion is an important ion which predisposes towards hypertension when you use sodium chloride. But in sodium bicarbonate, the hypertension is not a major threat. So when you treat metabolic acidosis, it has been shown that the progression of renal failure can be reduced. So you're able to produce some degree of reversal of chronic kidney disease by reduction of the GFR decline. So, dear friends, I have made a very strong pitch for changing management of early stages of chronic kidney disease by looking at various factors which impact the renal, intrarenal bioenergetics and also phosphorus metabolism. So a drug which combines niacin, sodium bicarbonate, and the calcium carbonate will be very welcome to be used in patients with very early stages of chronic kidney disease to prevent the progression. Thank you very much.
Okay, so are we ready for questions? Can you hear me, Doctor?
Yeah.
Okay.
Yes.
Okay, so the first question is comes from Shannon, and she says, I have polycystic kidney and liver GFR 24. Would this still benefit me?
See, in patients with GFR of 24 ml, the CKD stage is close to stage 4. The benefits are not going to be great, but you can just look at your phosphorus levels. If the phosphorus levels are anywhere above 4.5 milligrams, definitely you can use this drug, niacin.
Okay. And then I'm going to put this other, can you see the chat?
No.
No. Okay. So I'm going to try to read this. What approach would you take for a patient with fibrillary GN, a rare form of kidney disease?
Yeah. So this is a different kettle of fish. This is due to hypersecretion of these fibrils from revved up immunological system, especially the plasma cells. And this requires a totally different approach where you need to curtail the plasma cell activity with drugs which are not the topic of this discussion. So this is totally different. But when these patients go in for renal failure, and when their glomerular filtration rate comes down, then definitely these people will require drugs to reduce the phosphorus and also to reduction of the acidosis. So these the molecules that I have discussed also will have a role to play, but not at a direct, it will not have a direct impact.
Okay. Okay, so this next question is, what are your thoughts on the, and I'm going to spell this word, Jyn as in Nancy, ARQUE. Janarc.
What is that?
Janarc.
I'm sorry.
Um,
I don't get it.
Jyn ARQUE.
I'm sorry. It
I don't know
doesn't
if
make
one of the
sense to
other
me.
panelists
Yeah.
could.
So we'll see.
Okay, the next question is, I don't know if one of the other panelists would be able to pronounce that word so that the doctor can understand it. Feel free to unmute yourself.
So I
But
think we can skip it and then go
yeah,
to the next
I'm
question,
yeah, I'm
please.
going to go to the next question. So, what is the maximum niacin intake in one day?
Yeah. So I have always been very careful in not using high doses of niacin in my patients. I use anywhere between 250 to 500 milligrams of niacin in patients with early stages of chronic kidney disease.
Okay. Next question from John. He says, I am AKI or AKI due to use of dye twice to place stent, then some medication for heart attack. I am on dialysis for 1 year. My GFR is 8. Will this help?
I don't think so. So you have come to a stage where it is dialysis requiring renal failure. So you can't call your condition as acute kidney injury, which is already crossed a stage, and your chronic kidney disease. And so this drug is unlikely to help to reverse the renal failure, but it will definitely help you in your cardiac manifestations by reduction of the uh, calcium calcification of your coronary arteries.
Okay. Next question from William. It says, if I wanted to take baking soda, how much teaspoon should I drink with water? I have high blood pressure also.
So I wouldn't advise direct ingestion of baking soda which is available in the kitchen. Ideally, that you should have a micronized form of these tablets which are available, and the dose of the sodium bicarbonate varies. I already told you that the 500 milligrams contain close to 6 milliequivalents of sodium bicarbonate. If you do not have severe renal failure, a single dose of this drug, a single dose of 500 milligrams will do.
Okay.
But I would advise to talk to your physician. Yeah.
Okay. So next question is, I am at stage 3B. Can any of this help me?
Definitely, patients with stage 3B, if you check your serum calcium levels and your serum bicarbonate levels, if they are on the outside of normal, and if your serum phosphorus levels are going up, this drug can be used.
Okay. Is this protocol effective post-transplant to support the kidney?
Patients with post-transplant, when the kidney is doing well, we have no reasons to use this because these are not reached a stage where it has been used in kidney transplant patients. So I would advise caution and not use this in patients who have already undergone a kidney transplantation.
Okay. Next question. I have stage 3 CKD, GFR 50. Will this protocol help slow the progression or improve it?
I feel so. I feel that this drug can be tried with a very careful look at your results over the next 3 to 6 months with your physician's close advice.
Okay, so I have someone who that one question where we were not able to understand that
Yeah,
word. This person is saying it's generic is tolvaptan,
yeah,
Tolvaptan.
yeah, yeah.
So the
So what
question
is it
was
about?
the question was, what are your thoughts on that medication?
Tolvaptan is a drug which is generally used in patients with polycystic kidney disease. So this has to be used very in specific stages of the polycystic kidney disease, and this has been shown to retard the progression of the cyst. But this cannot be used in all because this drug has got side effects and it has to be very carefully used under very physician's guidance, especially nephrologist guidance.
Okay. Next question, what is the maximum? Okay, so as far as the maximum
We have
niacin,
already spoken.
yeah,
We have
max, it
already
says,
we
yeah,
have already
max
given.
dose FDA approved is up to 6 grams a day.
Yeah,
Okay.
yeah.
All right.
But
High
I
safety
wouldn't go to
plus.
that.
Yeah.
Yeah.
Okay. So, okay. So John says I joined a bit late, so I need to take sodium bicarbonate and niacin. And what's the dosage and anything else?
Now, what is your disease? Do you have a disease which requires these drugs? Any early stages of chronic kidney disease? In such situations, niacin in small doses can be started,
Okay.
and along with sodium bicarbonate.
Okay. We'll see if he answers that question. Um, so Stephanie is correcting her question. She says, I'm 9 years post-transplant. My GFR lowered over time to 57. Would this be helpful to slow progression?
I think 57 is very good. So I don't think you should look at further lowering. 57 is good enough after nine years. So I wouldn't use any new drugs on your very precious kidney. So better you continue with whatever you have been taking. And so you are doing well over the 9 years. Yeah.
Okay. And then as far as John's previous question about sodium bicarbonate and niacin, he says he is AKI slash ESRD 1 year on dialysis. So he's looking for
Yeah.
like what the
So
proper dosage would be.
no, so the proper dose will be 500 milligrams of niacin, and sodium bicarbonate will be anywhere between 500 to 1 gram per day.
Okay. And let me see here. Um, if a patient was about to start dialysis, can the niacin protocol help or reverse their condition?
I wouldn't say that because once the renal progression has happened to an extent that it requires dialysis, reversal is not possible. That is why I always emphasize that you need to start very early when this GFR is between uh, 80 to 60, and that is the stage, the so-called stage 2 CKD, and this is the stage at which it is amenable for correction.
Okay, so Claire has asked a question, and so she says if CA carb will cause kidney stone.
Calcium carbonate.
Okay.
So calcium carbonate, yeah, calcium carbonate has been linked, large doses have been linked with increase in the calcium absorption, and that can, in the long run, produce calcium stones in those who are predisposed towards it. But when people develop oxalate stones, in fact, calcium is given as a therapy. Calcium tablets are given as therapy for people with oxalate stones to reduce the calcium absorption from the gut. So, taking a tablet of calcium in those who are not predisposed towards calcium stone is not a major issue.
Okay. And will the niacin protocol impact my glucose levels if I have diabetes?
You need to, this is an individualized decision. You check and keep a watch on your glucose levels, and you need to tailor your therapy. Low dose niacin is not shown to be very glucotoxic.
Okay. That is it for the questions. So I just want to say thank you all for your questions and for attending, and special thanks to the doctor for his information and invaluable presentation, and to Health Defender for hosting the event. If you'd like a recording of this webinar, please let us know. We'll be happy to send it to you, or you can find it on our website once we get it there at healthdefender.care. So thank you, everyone.
Thank you.
Okay, bye-bye.
Thank you.